Welcome to This Week in Health IT, where we amplify great thinking to propel healthcare forward. My name is Bill Russell, healthcare CIO coach and creator of This Week in Health IT, a set of podcasts, videos, and collaboration events dedicated to developing the next generation of health leaders. If you missed our live show, it is only available on our YouTube channel. What a fantastic conversation we had with Director for David Muntz, Sue Shade, around what's next in health IT. You can view it on our website with our new menu item, appropriately named Live, or just jump over to the YouTube channel. And while you're at it, you might as well subscribe to our YouTube channel and click on Get Notifications to get access to a bunch of content only available on our YouTube channel. Live will be a new monthly feature only available on YouTube. How many times did I say YouTube in that paragraph? Subscribe to YouTube. We're going to have some great stuff over there. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. They reached out to me to see how we might partner during this time, and that is how we've been able to support producing daily shows. Special thanks to Sirius for supporting the show's efforts during the crisis. Now, on to today's show. All right, today's conversation is with Kristin Darby, Enterprise Chief Information Officer for Envision Healthcare. Good afternoon, Kristin, and welcome to the show.
Good afternoon, Bill. Thank you for having me.
Well, I'm looking forward to the conversation. And thanks for taking the time. I know this is a really busy time for you guys. Tell us and tell the audience a little bit about Envision Healthcare.
So Envision Healthcare is a national medical group. We have 27,000 clinicians that deliver approximately 35 million annual patient encounters. Our clinical services are provided at approximately 1,250 locations across over 40 states. And our medical group specialty expertise includes emergency medicine, anesthesia, radiology, women's and children, and surgery. AmSurg is our ambulatory surgery division, where we manage over 260 centers. And for patients receiving care at home, Evolution Health provides patient-centered care for home health, infusion therapy, and also provides hospice services.
So the impact of the pandemic was probably pretty significant. Give us some idea of what you guys experienced during the pandemic.
Well, we recognized early that technology helps relieve the COVID-19 strain, and it protects clinicians, which is critically important to us in addition to protecting patients. As a result, we quickly mobilized our efforts to deploy telemedicine. But I think some of the other observations just about the pandemic in general, collaboration has really been unprecedented. Everyone's recognized it's a public health crisis, and the speed of execution is at an all-time high, which has really been required in this dynamic situation that has been changing on a daily basis. One area specifically that I've been really, really pleased with is the expeditious data sharing and really just the collaborative effort that has enabled us to develop a very robust community-based biosurveillance system that we're augmenting with community-based information and then the information we're seeing with patients that are presenting on the front line during this crisis. Envision's very much a data-driven organization, so that's really been critical for us to have the information to be able to respond most effectively on behalf of our hospital partners, the clinicians, and then also helping us just things like prioritize resources and understanding where we need to be focused to respond next in what geographic area, et cetera.
Yeah, so it's interesting you bring up, two things I'd love to talk about. You talk about biosurveillance. You talk about a data-driven organization. There's no doubt at this point that IT plays a significant role in business agility and agility, political agility as well. You guys had to react and respond pretty quickly. Give us an idea of, how you guys think about the platforms and the architecture in order to give you the ability to respond.
Yeah, so I think when this was evolving, nobody knew what to expect, right? I think we're all still learning very much. And I think just a bias for me has always been, I prefer open architectures. I believe very much in interoperability. And I think our technology portfolio is reflective of that. But when we started this, we had assumptions as to needs that we were going to have. And what we tried to do is understanding that there could be supply chain disruption or there could be other types of challenges that occur. What we did is each of those assumptions, we tried to have 2 to 3 different ways of addressing it. And we knew some would fall. What we didn't want to do is be standing there and have to tell our clinicians or any of our operating units that we couldn't deliver in times that they needed us most. And so as we did that, certainly we did have things fall out. But, I think some of the things that really came through is some of the more robust just platforms that we had were scalable. They were able to perform. Luckily, we have an incredibly skilled engineering and software development team. And quite frankly, most of what we've done, we've built. And we've built in an incredibly rapid turnaround time. And it's not things that I think with the evolving use cases that have occurred, and a lot of this has really been in the virtual health area. So we had kind of the remote workforce change that occurred, and then there's been kind of the frontline work of really supporting the clinicians and the patients that they're serving around the clinical needs that have evolved. With both of those, but more on the telemedicine side, it's really required those advanced technical skill sets and also the deep knowledge from a clinical informatics perspective and just awareness of how a hospital operates, how an office practice operates, and what is the right technology to address and meet the needs most effectively based on the situations that were evolving predominantly in the surge areas. But we're certainly, for example, telemedicine, we have distributed in 11 states right now. But the surge areas were where most of our extensive learning was occurring at a very rapid pace.
So let's talk about telehealth, because that's, given the nature of Envision Healthcare, you guys have really relied pretty heavily on telehealth and remote monitoring and those kinds of things going into this, or as a result of this. Give us, and I really want to get pragmatic here, because a lot of systems have come on and said, "Hey, we scaled from this to this," and that's really neat. But how have we scaled? How have we experienced it from a clinician side, and how have we experienced it from a patient side? Is really the direction I want to take you. So first, let's talk about how you guys scaled it. Did you have like a national platform that you just called them up and said, "Hey, give me another 10 licenses," or was it more sophisticated?
So, as I said, in each of those assumptions, and one is that telemedicine was going to be needed. I think there was a lot of discussions around that in February, but was it, the traditional urgent care type call, or was it an office-based call? In an acute setting, I've had many telemedicine programs over the years, but it was things like tele-ICU or just very particular use cases. In this situation, we didn't know what to expect. And so we did go down the avenue of some of the telemedicine platforms that you could purchase, and they were dealing with a surge also of demand. And it quickly became clear that the use cases we were being asked for would have been built pre-COVID, just for out-of-the-box solutions. And the time frame to get anything addressed was just not going to be there. So if we really wanted to meet the needs of our clinicians, and I will tell you that the 4 drivers that became really, really clear was initially was PPE, which the personal protective equipment we've all heard on the news, that in the areas that were surging, the limitation of PPE was really a number one factor. How can we use technology to help reduce the need for PPE, or if somebody was doing something minor that maybe didn't require physical contact, but maybe it's looking at a monitor, right? Do they really need to get fully dressed in PPE to be able to see what the monitor says to enter a room? So just real simple needs that really aren't hard technically, but equipment has to be there that wasn't there for that person. So the second was alleviating just the capacity strain in the hospitals. The third was pre-screening patients that were suspected COVID. Lots of discussions initially about tents, which is, we started designing for that. And then front of emergency medicine entrances to pre-screen. I would say the front entrances took off. We absolutely had some tents we were supporting, but initially, if you asked me, I would have thought we'd have hundreds of tents. That didn't necessarily emerge to the scale that we expected. But what did emerge is the need for specialized treatment consults at a scale that wasn't anticipated initially. So it was emergency medicine, but the need to be able to see the patient because COVID-19 is something new and everybody's learning, across all disciplines. And the more that they can see and interact with the patient, the better guidance they're able to provide. And the more that they're able to talk to the other providers, especially critical care areas and other areas, we were doing a lot of specialty consults. So a lot of our initial designs were around those concepts. And when we talk about provider adoption, I think there was a lot of discussion about it in week 1, 2, how would we use it, what's the perfect workflow, and then the surges started hitting some of the areas. And the absolute necessity for it became very clear. A lot of those other anticipated challenges were overcome very, very quickly because the need was clear. Our providers, we had a few that really, really embraced it from day one, just tech savvy. And we knew when we were designing this, it had to be easy and it couldn't be complicated. And some of the challenges we had was the staff was evolving, right? If you think of the surge area, you might be redeploying people from other facilities. Maybe credentialing hasn't gone through yet. Maybe user accounts aren't provisioned. You have experience with this. It usually takes a little bit of time, right? So all those processes at every location weren't necessarily tuned to respond to 10-minute requests, right? So we were trying to figure out how do we fit in there and make sure that this continues to be secure, which throughout this process, we've never compromised on any of the security standards or HIPAA requirements, because those are absolutely critical to us and we feel is a responsibility to our patients and the health systems that we serve the patients on behalf. As we were designing that, I'll give you a couple examples of just some of the use cases that appeared that I certainly wouldn't have anticipated that initially. So we had a mother that was in, I believe, late 50s, 60s, admitted, adult children, brought her to the hospital, not in good condition, and they had to leave her at the emergency department. Because during the crisis, the visitation is suspended for family and friends. So mother admitted almost immediately in very critical condition, ended up being intubated. But normally in a situation like this, a physician is talking to a patient, but also their family surrounding them about these are the options you have available to you. These are the courses of care we could take. And there's an exchange of pros and cons. Without the family there, these doctors were having these discussions with patients that weren't necessarily prepared to be making those types of decisions, right? Just difficult decisions and may not have been able to. What we were called about is how do we get the patients, us, the providers, which might have been more than one, and family all together where the family can see the patient and we can have a discussion about this. So we ended up designing a multi-point secure video conferencing solution. And initially it was for those meetings, right? Discussions about how to make critical decisions around patient care needs. But then it evolved to when the physician said, why disconnect the call? The family still wants to be connected and watch the patient, right? Or their family member and stay with them and support them and make sure they know they're safe. They can't be there physically to hold their hands. So why not be on video right there with them? Absolutely makes sense. Don't hang the connection up, right? It's a secure connection. And so those types of things, just replacing what is so just critical from a human perspective, really was important for us. Another one that the doctor came up with this, I just don't know that I would have envisioned this, is we had a critical care patient that was in the ICU, but was conscious, awake, and intubated. There's a very advanced bed called a roboprone bed that is often used for patients that have acute pulmonary complications. And this patient, COVID positive, but having complications with the lung that they felt that the bed, which puts you in a prone position, which is basically upside down, was the best course of action. So if you just think about being scared that you're COVID-19 positive, right? A patient, and this is a few weeks ago, still not a lot known, right? Lots of uncertainty. You're awake. You've been intubated, and now you're in a bed upside down looking at the floor. And between the bed and the floor, there's about this much room. And the challenge is, he said to me on the phone, how am I going to get a nurse down there to talk to the patient, right? Even if they laid on the floor and crawled under, they're not going to be able to give those personal updates that are so critical, just to be able to say, we're here for you. This is the status. This is what we're seeing. This is the path to recovery, and this is where you are on it. So what they did is they used the solution to put a tablet under the patient. And they were able to come on and say, we're here. You're doing good. Everything looks good, right? Checking in on you. You're not alone, right? And those are things that are so incredibly valuable for a patient trying to get through what is probably the most vulnerable point in their life. But in addition to that, just the fact that technology can help with that, I would have never anticipated that use case if you'd asked me that 2 weeks earlier.
Well, I appreciate you sharing those stories because, my father-in-law went into the hospital probably about 3 or 4 weeks ago, and we couldn't be there with him. And he has been in the hospital a couple times, and most of the time, the doctor or physician ends up talking to us about him. I mean, he's involved in the conversation, but it's with us, and I can see that as a really real need for, I don't know, just the whole care experience and everyone feeling comfortable. The last thing, because I've taken up a fair amount of your time, but the last thing, you seem to be an organization that leans more on creating your own solutions as opposed to relying on out of the box. Is that accurate? And then how has that played out through this pandemic?
Yeah, so I would say that the majority of what we purchase, we would always lean towards buy as a preference, unless there's a specific reason around some type of proprietary activity we're doing or something that is a differentiator that we're developing. But otherwise, we would always look to buy, especially if something is commodity-based. I think what drove us from a development perspective here was clearly time to respond based on the evolving need and the inability to have a purchase option that was able to respond in the way our clinicians really needed it to respond to be able to meet these unmet needs. If we gave them a traditional structured, station or cart or, just these things that were created for other types of use cases, we wouldn't have been able to have the flexibility that we've been able to have and truly benefit not only our hospital system partners, but most importantly, the patients and their families that are going through this crisis. I described the acute setting, but we've been using this in our office practices, also in post-acute and urgent care centers. It's really been a valuable tool to help us navigate this crisis.
Fantastic. Well, I really appreciate you sharing. And the thing that really has come through is responding to the needs of the clinicians, listening to them, hearing what their needs are, determining build versus buy, and then moving forward with the right solution to meet them. That's what really comes through. Kristin, thanks a lot for your time. I really appreciate it.
Thank you. I appreciate it.
That's all for this week. Special thanks to our sponsors, VMware, Starbridge Advisors, Galen Healthcare, HealthLyrics, Sirius Healthcare, and ProTalent Advisors for choosing to invest in developing the next generation of health leaders. If you want to support the fastest growing podcast in the health IT space, the best way to do that is to share it with a peer. Send an email and let them know that you value and you are getting value out of the show. And also, don't forget to subscribe to our YouTube channel while you're at it. Please check back often as we will continue to drop shows until we get through this pandemic together. Thanks for listening. That's all for now.